All right, it looks like it's time for us to go ahead and get started. Hello, everyone, and welcome to this month's Northwest ATTC webinar, which we are offering in partnership with Seven Directions. I'm Jennifer Verbeck, and I'm your host for today. We're excited to have a panel of speakers, including Danielle Eakins, Paul Hunziker, Lindsay Parrish, and Evelyn Mujica Larson presenting for us today on incorporating Indigenous evaluation into a tribal clinical supervision learning collaborative. Next slide. We have a couple of quick housekeeping things. If you have any questions for our presenters, please type them into the chat box at any time and we'll try to answer some as we go through the presentation, and whatever we don't get to, we'll just save for the end. Next slide. You'll be getting an email at the end of today's webinar. It has a survey in it. Please take that survey as it makes sure we're bringing you content that you're interested in, and it also helps us continue offering free or low-cost events such as this one. That email will also have a link to download the slides from today and a link to our website where you'll be able to find a recording, and that should be available later this afternoon. Additionally, we'll be sending everyone who attends this live webinar a certificate of attendance, and it takes us about a week to get those out. You don't need to do anything to get that certificate unless you're watching this in a group. If that's the case, have someone in the group email us within a business day with the names and email addresses for everyone who wants the certificate. And you'll see our email address there. It's northwest@attcnetwork.org. And then with that, I'll go ahead and turn it over to our speakers today. I know we were having a couple of technical challenges, so hopefully we've got those all worked out. But thank you guys for joining us today. We really appreciate your time.
Thank you, Jen. So, hi, everyone. I'm Paul Hunziker, one of the presenters today. I'm going to be taking us through this land acknowledgement here. Let me read from this. So, in applying a lens of cultural humility to issues of diversity, equity, and inclusion, Northwest ATTC offers this land acknowledgement for today's event. Our work at the ATTC intends to reach the addiction workforce of the Health and Human Services Region 10. That includes Alaska, Idaho, and Washington. This area rests on traditional territories of many different indigenous nations, including tribal groups with whom the United States has signed treaties with prior to granting of statehood. Please join us in support of the efforts to affirm tribal sovereignty and in displaying respect and gratitude for indigenous neighbors. I want to add to this as well of acknowledging uh, that the traditional lands that the University of Washington are on are the traditional home of the Duwamish, the Muckleshoot, the Suquamish, and also the Tulalip tribe nations. Without them, we would not have access to this working, teaching, and learning environment. I have the opportunity to thank the original creators of this land who are still here. I also want to acknowledge the lands that I'm on, from where I'm joining you today. And the lands that I acknowledge that these are the this is the traditional home of the Puyallup and Coast Salish tribes. I also take this opportunity to thank the original caretakers of this land who are still here. I'm going to put into chat now a link to the land recognition map. If folks would like to follow that, that would be great. And find the traditional peoples of the lands that you are on currently. And if you could type those into chat, that would be great. So we could do a full land acknowledgement from all the different areas that we're coming in. Thank you for participating in that. Let me put my acknowledgement in there. Great. Thank you, everyone. Okay, next slide. Thanks. So our learning objectives for today. What we're going to be doing, we're going to be looking to obtain a greater understanding of Indigenous evaluation approaches, and we're going to be looking at that extensively. We're going to also identify how Indigenous evaluation, including values, knowledge, and visions, can be incorporated into your clinical supervision efforts. We also are going to lastly identify how you can ask for and advocate for Indigenous-centered clinical approaches within your communities. So those are the items that we're looking for to get today. Next slide. So I wanted to start with the history of this tribe-focused clinical supervision training that we've been offering, and it's actually started in 2020. So prior to 2020, there was a clinical supervision training that I was teaching, and I had inherited from Dr. Steve Gallen and John Porter, who had been teaching it for many years. And it was a very solid set of skill set for clinical supervision. There was a recognition over the years of teaching, because we frequently teach at many of the different, for different tribes. And there was always a question of kind of how do we adapt this to work within this setting, in this different cultural setting, or this specific cultural setting. So the idea was kind of percolating for many years. In 2020, I had started what was called the Clinical Supervision Immersion Project, which was an extended version of the clinical supervision training. And while doing that, we realized that we could actually add more adaptation in. And David Jefferson, who formerly with ATTC, and originally came up with the idea and kind of worked with me on getting it set up. We ended up having a listening session to gather information from the different stakeholders in all of the 4 states of Region 10. We got a ton of information out of that. One of the big things we also got was Leah Nicolucci was our original, worked with us, and she had a ton of experience working with several different tribes. And Leah and I ended up working extensively together to adapt the current supervision setup, and add cultural aspects within it. We always knew that this was going to be an ongoing and constantly evolving piece, and every year we've offered it, we've looked for new ways to incorporate more cultural components into it and to make it more and more relevant, to make sure that it's meeting the needs of the tribes. In 2021, we launched the first cohort. Lindsay, who's here with me today, is now co-instructing. She was actually part of that cohort. And then Lindsay joined in 2022 and has been Lindsay and I have been teaching it ever since. And in 2025, Danielle has come in and has been working with us to continue this work of trying to add more cultural vision and more cultural components to the training. And so it's a major part of us continually evolving the program. Next slide. I'm going to hand it over to Danielle.
Hi, everyone. Thank you so much for joining. I'll just start with some introductions about myself and about Seven Directions. So I am a research scientist at Seven Directions. I'm also the Indigenous Communities Advocate for the Northwest ATTC, where I joined last year. A little bit about my background. I'm a clinical psychologist by training. I come from a multiracial background. I'm not Indigenous, and I've worked with Indigenous communities for the past 15 years. And so again, I'm so excited to join today. I wanted to speak first a little bit about Seven Directions. So we are housed at the University of Washington, and we were the first public health institute in the nation to focus solely on Indigenous well-being. So as such, our mission is to advance American Indian and Alaska Native health and wellness by honoring Indigenous knowledge, strengthening tribal and urban Indian public health systems, and cultivating innovation and collaboration. On the right is one picture of us as an institution. And I'd just like to note that we have so many wonderful team members, and this is always a collaborative effort. So next slide. So one of the ways we have supported our mission is to champion for Indigenous evaluation. Indigenous communities have engaged in review and reflection to understand the impact of community decisions since time immemorial. So after many rounds of feedback, we conceptualize Indigenous evaluation as a long relied upon use of Indigenous ways of knowing and deep community involvement when assessing an effort's effectiveness or community impact. So I'll soon be talking about 7Directions Indigenous Evaluation Toolkit and how it addresses public health efforts and how it was tailored for the Tribal Clinical Supervision Collaborative, which Paul just talked about. So next slide. So before we fully focus on Indigenous evaluation, I'd like to share about overlaps and divergences between Western and Indigenous evaluation for public health efforts. So while both involve the systematic gathering of information about community services, needs, and outcomes, Western evaluation has an emphasis on objective knowledge types, and the evaluator is often an outsider to the community. There are outside or funder-driven questions addressed, and there's an emphasis on external validity. It can include community participation in, but rarely ownership of the evaluation process. When we look at Indigenous evaluation, there's an emphasis on holistic knowledge types, people involved, and relationality. There are community-defined questions addressed, and there's an emphasis on local relevance. There's deep community involvement and ownership, capacity building, and data sovereignty. So if we could go next. So additionally, in terms of conceptualizing our definition of Indigenous evaluation, I want to discuss that evaluation is inherent across many disciplines. So whether that is public health, psychology, social work, or many other disciplines. However, it may be packaged a little differently depending on where you are focused on. So our 7Directions Indigenous Evaluation Toolkit, which I'll talk about next, focus mainly on opioid overdose prevention and public health program evaluation broadly. And as you see on the left, that often includes a systematic approach to examine effectiveness of programs. Data is used for continuous improvement. There may be things such as logic models, cost analysis. And then in green, in addition to those things, Indigenous evaluation often includes revealed and traditional knowledge, tribal ownership of data, metaphor, and storytelling. So when we think about Indigenous evaluation in other disciplines, we could think about things such as evidence-based quality improvement, direct service provider progress assessment, and client progress assessment. So I'm guessing for myself as a clinical psychologist and many others that have joined today, those are some of the lenses that we think about when we think about evaluation and direct clinical services. So we might think about things such as, is my team or program serving our community? Am I meeting my goals as a clinician or supervisor? Are my clients meeting their goals? Is there symptom reduction and increased functioning? Our favorite, am I meeting RVUs, relative value units, or service number goals? And in addition, for Indigenous evaluation, in addition to those things, are we creating a life with joy, purpose, and connection that is grounded in community strengths? Am I appropriately centering my lived and professional values in my work? And do we have culturally grounded approaches, honoring individual gifts and respecting protocol in this? And so if we could go next. So in order to meet a gap that we were seeing in Indigenous evaluation support for public health and opioid overdose prevention, we at 7Directions embarked on a multi-year community-based participatory research approach to creating a guide that includes actionable phases and steps, worksheets, and a fictional story of a behavioral health team. So our actionable process was based on consultation and approval from the American Indian Higher Education Consortium and Dr. Joan LaFrance to use the Indigenous Evaluation Framework, a seminal Indigenous evaluation work for higher education settings, as the foundation for our toolkit. So as such, our toolkit is based in core cultural values such as Indigenous knowledge, people of the place, centering family and community, honoring our gifts, and respecting sovereignty. If we could go next. So we released the toolkit in 2023, and as I mentioned, it's a continuous flexible learning process with a community center or a community goal at the center. So for tribal clinical supervision, I was excited to work with direct service providers for the first time on phase 1 in vision and designing for their learning collaborative. So you can see that in green there. And next. So based on the toolkit, in TCS, we focused on developing individual and group values, visions, landmarks, and knowledge gathering plans, which I will talk about next. I'd also like to note that our toolkit uses a river metaphor to describe the Indigenous evaluation journey. So you'll see that reference throughout. You can go next. So for the Tribal Clinical Supervision Collaborative, we started with our values and had a wonderful discussion in terms of what values guide the training collaborative as the foundation. And folks answered many things, and I'll just note a few here on the right. So values such as relationships, safety, integrity, accountability, trust, humor, curiosity, and professional development. We could go next. From values, we then move to visions. So what visions are is they outline driving motivations and purpose for doing this work. They can set the foundation for collecting knowledge to assess progress, and they're an ideal future state grounded in a group and community values. So we ask questions such as, what impact do you envision if your supervision is successful for individual visions? And what impact do you envision if the TCS training collaborative is successful for group visions? Next. So you can see here some individual visions as a supervisor. And I want to note that even though they are individual visions, they include community in them. So supervisors noted visions such as, I will learn more about traditional ways of healing to expand my knowledge to better supervise and provide care. I will learn more about the youth in my community in order to better supervise, serve, and equip the future elders of the community. And I want to reconnect people to the Indigenous strength that guided us for generations. You can go next. So after multiple rounds of discussion, we then determined our group or cohort visions for the collaborative. And those were the first vision being TCS members strive to co-create spaces for safety, learning, and growth. TCS builds relationships that last after the cohort time, including mentee and mentor relationships. And TCS honors diverse Indigenous history and strengths. Next. So we then moved from visions to landmarks. So those are ways to measure your success toward your vision as you progress in your journey. They're evocative, sensorial, aligned with how does this look, feel, sound, and taste. They are akin to indicators in a standard logic model and use multiple types of Indigenous knowledge, such as empirical, revealed, and traditional knowledge. I'd like to note that all of these different types of knowledge and details are in our Indigenous evaluation toolkit. We just have limited time today, so I'm not going into some of the details with those. So we could go next. So finally, from our landmarks, we mapped knowledge gathering plans, such as when will you look for these markers and who will be there. So for the time, I'm just going to show some of our work from Vision 1, which is TCS members strive to co-create spaces for safety, learning, and growth. And some of the landmarks that we noted in terms of how do we know that we're getting there are things such as active participation, feeling comfortable sharing, mutual respect, sense of community, and welcoming cultural protocol, Indigenous language, and land acknowledgements. So in terms of who will be there and when will we look for them, we noted things such as the folks that will be there are the cohort, supervisors, supervisees, ancestors, elders, youth, and other community members. And we'll look for some of these immediately, and some will happen over time as relationships develop. So now that I've talked about an overview of our work, and I know that was a lot packed into a short amount of time, Next, I'm going to have Paul, Lindsay, and Evie talk a little bit about themselves and talk about their experiences in the TCS cohort with Indigenous evaluation, and hopefully bring some of these approaches and this overview that I talked about to life. So we could go next and then turn it back over to Paul, Lindsay, and Evie.
Thanks, Danielle. So, yeah, let's and sharing some of my experiences here. I know I've been working with ATTC for Northwest ATTC for some time, since about 2015, I believe, and I've been teaching supervision since that time. And so, it's been really exciting to be able to continually develop and add more and be involved in um, creating and moving this project forward. Um, I guess in some of the evolution with it as well, and kind of finding out with this Indigenous evaluation piece coming on. First heard about it in 2024 as we were kind of coming to the end of the grant cycle. Brian Harlitzer, the co-director of the Northwest ATTC, let me and Lindsay know that Danielle would be coming on to be helping us continue to add more to the tribal focused clinical supervision project. We were excited for this, to be able to continue to add more in, because one of the challenges with this program has been we've largely taken what is a Western clinical supervision approach and tried to adapt and shift it, and that always was kind of a question mark of how to is that the right approach? How do we adapt it? It's what we had. We ended up when Leah and I were working on this, we realized we really couldn't rebuild from scratch. Though what we ended up, both of us, Leah and I, and then now Lindsay and I, have always recognized that over the years we wanted to keep adding, shifting, and growing the project to make it much more culturally relevant. And so Danielle coming on has been a huge piece. Since Danielle did join, there we've had. No, you've come in twice. I'm trying to make sure it was at least twice that you came in, Danielle, I believe, to work with our group, and each time has been fantastic. We didn't have enough time to get all the way through the material because there was so much discussion, so much excitement, and so much interest in this. And it really is, it's a part that really feels like we're connecting to the cultural focus that we've been aiming for. Lindsay, I don't know if you want to add anything.
Sure, absolutely. To introduce myself really quickly, my name is Lindsay Parrish. I am an LICSW. I work for a local tribe in Washington full time, and I've had the honor of getting to work with Paul and learning from Paul and Leah, as you saw on the slide first, and then asking me to be a part of this facilitation of the tribal clinical specific supervision since 2022. I am an enrolled member of the Northern Cheyenne Nation out of Montana, and I'm a Crow, Blackfeet, and Turtle Mountain Chippewa descendant. So this teaching, this clinical supervision cohort, and this ability to learn, adapt, and provide a space for continued learning and sitting with other supervisors who are working in tribal communities is near and dear to my heart, and is something that I've not only wanted to grow and learn in, but have had the opportunity to teach while also doing that in the work that I do directly. It has been, as Paul stated, a journey in growth and change and flexibility, and trying to ensure that we're bringing in pieces to support clinical supervision in a very mindful and holistic way that go back to those decolonized ways of thinking that support community first and foremost, while also supporting the people that we're working with because they are part of that community, and how we do that. And then having Danielle join the team and bring in the Indigenous evaluation allowed for us to also measure it in a way that was still connected to the roots of what we're doing, looking at it from a lens of Indigenous perspective, which is really, really important in this teaching and this facilitation of this tribal specific clinical supervision. So this journey has just been about flexibility, growth, stepping back into community as a way of learning. And it has always been, for me specifically, a beautiful thing to also step into this and learn from those that are stepping into supervisor roles or have been supervisors and have different ways of learning, especially those that are Indigenous in their backgrounds and descendancy. They have a lot to bring, to share, and grow. And so with this evaluation, we've been able to take that knowledge, take all of these different experiences, feedback, goals, and together continue to create something that is meant for growth, not only in the clinical teams we're working in, the supervisors, the supervisees, clinicians, providers, but for the community first and foremost. Evie, do you want to share your experience as a cohort member?
Evie, you're on mute. Evie, you've got to unmute yourself.
Sorry about that. So I'm Evie Mojica Larson, Dina'ina Athabascan, and Puerto Rican from Nundalton, Alaska. I'm currently the behavioral health aid clinical supervisor for South Central Alaska, so like 17 different communities. I'm joining from Wasilla, so hopefully my connection stays. And honored to be invited here to share my experience and my passion for this course. I get emotional every time I come on because my experience as an Indigenous clinician and also an Indigenous supervisor, I've not had one myself. And so it's been kind of lonely, and being in this space with other people that provide services in the communities and are Indigenous, it makes me happy, makes me emotional because I've just not had that. And so this course has been super helpful in being able to have a safe space to talk about the unique situations that we face when we're working with people that are actually in the communities or working in spaces where they're providing services to Indigenous people. You know, working in, living in these tiny communities, we run into a lot of what seems like unethical situations. And throughout my journey becoming a clinician, having supervisors that didn't have this experience, we butted heads a lot because I'm a storyteller and the people that I meet with are storytellers. And even in trainings like leadership trainings, and I share my part, they're like, your stories are kind of circular, spiral. They don't really follow the steps. So it's been so nice to be able to share those things in a space like this, and also to have tools, actual practical tools that we can use. Most of the time, we get our clinical training and we're given our Alaska rules and guidelines, but we're not actually given tools that day one, this is how you can start that foundation of supervision. And this is how we're going to work together to build that relationship, but also to help build the skills of the people that we're providing supervision to in a way that builds them up and grows that passion that they have that brought them into this field. So I've been super thankful. I get excited every time we come together. So that's me.
Thank you so much, Evie. It's wonderful to hear everyone's experience, Paul, Lindsay, Evie, and working with the cohort as well, and seeing some of that joy and that safe space to talk about how we would incorporate, our values, our visions, and have, as you said, Evie, those practical skills in addition to having the space to discuss, all of these pieces, whether it is the strength and the joy in community, as well as historical trauma and loss. And in working with Indigenous communities from the lens of a clinician, how do we also have that space when we're working with things such as substance use and opioid overdose or overdose generally, where there's a lot of pain there as well. And so I think I saw that, again, that full circle of all of those pieces coming together in the TCS. So I don't know if Paul, Lindsay, wanted to add anything else in terms of experience before we keep going.
I can't think of anything more to add at the moment. No. Lindsay?
No, I'm not thinking of anything else off the top of my head.
Yeah, so we could go ahead to the next slide. Oh, and I think the next slide after that. So I wanted to talk a little bit about next steps. As I said, this was the first time in a really dedicated fashion that we were using the toolkit, which again was originally developed for public health efforts for direct service providers. And there's been a lot of pieces that I see as overlaps, and then some that we would definitely need to tailor. So I would really like to continue to get feedback from direct service providers in terms of, are these pieces landing? How would they incorporate into your work, either as a supervisor or for the work that you're doing with clients or with communities? And it would be great to hear from folks here thoughts on it as you are maybe seeing it for the first time or you are already incorporating some of these pieces. What does it look like for you? So from there, again, getting more feedback and potentially developing a direct service provider toolkit. I mentioned the process that we did with our toolkit at Seven Directions, and I didn't mention the whole history with it, but really this was a multi-year effort with so many different folks providing feedback. And that's always how we work at Seven Directions, that this is not knowledge that is inherent to us, but really this is knowledge of community from time immemorial. And so we did, pilot phases, launch phases, had a community advisory board. So all of those were key in terms of developing something that was relevant. So I'd like to do that, potentially with direct service providers. Um, and another thing that comes to mind for me is, how do we advocate to organizations, leadership, and funders for protected time for direct service providers? So again, I'm very aware as a direct service provider myself, having worked in big organizations like Veterans Affairs, hospitals, things like that. They do not give us much time to do things in addition to seeing clients or seeing patients and checking off boxes. And I want more time for us to be able to do stuff or do items like this. And again, oftentimes what we need for that is protected time. So again, I know that pieces such as this would really make our work a valuable time that we spend. But I think that we would need protected time in order to do this. And what's been really great about the Indigenous Evaluation Toolkit is that our funders, such as CDC, National Networks for Public Health Institutes, Safe Spaces, or Safe States, have given us the time in terms of our relationship building to see how this is very valuable. And that we have the time as a public health institute and advocating and working with communities, tribes, tribal epicenters to have this time protected. So again, I think we would need to do that for direct service providers and see how that looks. So one thing that I want to also highlight is us at Seven Directions, as well as the Northwest ATTC. We have no cost training opportunities for Indigenous evaluation and for the tribal clinical supervision. So I so recommend for folks that are joining to look into that piece. And also I really look forward to collaborating and hearing more about this and how we can transition this type of work broadly. So I think what we wanted to do next is hear from others. What questions do you have? What feedback do you have? And I think maybe there are some questions in the chat, so we could start with those and then open it widely. Does that sound okay with everyone?
Yeah, I think Danielle, the only question that I saw in here, and you kind of touched on it, was are you aware of any tools that assess the impact of historical trauma on individuals?
Yeah, there are a few of those. Ones that are coming to mind off the top of my head. I think it's the historical loss scale or historical loss associated symptoms. So there are some that have been developed that in particular do measure that. So in addition to those measurement scales, also being able to discuss in an open-ended way those pieces and have qualitative data or qualitative storytelling is a helpful way to look at that. So those are a couple things that come to mind. I don't know if others have additional scales or methods for that.
The only question that we had so far. Does anybody want to type in some other questions they might have?
Yeah, or feel free to come off mute and ask questions or give feedback.
This is Evie. We do have a questionnaire actually in the first meeting that we have with a person. We have, I don't know what it's called, but we get feedback from the person about like if we had a issue that we wanted to address with them, we asked them how would they want us to address it with them. And then we also check in with them later, asking them if they feel like they are being heard and that the staff that are working with the people that we serve, um, do they feel like they understand historical trauma? And are they feeling like they are being approached in a way that honors that? So we are always having those conversations.
Thanks, Evie, and thanks for folks in the chat adding other measures that are used. Evie, I'm wondering, and I'm thinking about the partners that we've worked with where relationship building takes a lot of time, um, and having the space for that where folks may not initially share those pieces, but as relationship again develops, that there's room for that and that there's sharing in regards to that. So I'm wondering, as you work with clients or as you work as a supervisor with supervisees, how you think about that relationship development and what it maybe looks like over time.
They schedule our visits 20, 30 minutes. So we have to be really fast. And I do direct care also. So I'm in the communities and I just say it right up front. And I feel like the providers do the same. You know, I know this is the first time we're meeting and it's uncomfortable to come into, our clinics. They seem sterile. But the way we set up our clinics, I feel like adds to the rapport building as soon as they come in. It's birch walls and ferns and chickadee pictures all over. And like, we're a part of this, the land that surrounds us. And so they're coming into a space that feels warm. So when we as providers, just even acknowledge our being able to provide services in their community and saying thank you, from the very beginning. I feel like that really helps build that relationship quickly. Um, and they're always excited to welcome us. So when we say, thank you for letting us work here, they're like, you're welcome. And then it happens naturally, I think.
Mm-hmm. And I'm hearing, what does it look, feel, sound
Mhm.
like? Those,
Yeah.
again, sensorial things when we think about that. And for clients coming in or for community coming in, when you have that environment that they can tell that there's safety in it, that bridge is starting to be met.
Mhm. And then when we do handoffs to each other, so they come and see the medical provider, and the medical provider hands the person over to me, invites me into the space, introduces me, and then I share what the provider has shared with me so that they're not having to retell their story to every person that comes into that room. And even the feedback that we get from that is like, oh, nice. I don't have to start all over again. So when we share those stories, you know, as the providers that work in the building together, people feel heard and they don't feel like it's just a number.
When you speak about that, another thing that comes to mind for me as a clinician when working with Indigenous communities, and also living here in Hawaii is that introduction of yourself, is so important. And sharing for me is a bit more holistic and, greater than I was taught in Western organizations or with my kind of Western training in a university setting. They used to talk about being a tabula rasa or being a blank slate as a clinician, and I don't follow that when
No,
I'm working with clients. Like it's important to say who you are and contextualize yourself kind of in the setting.
yeah. Where you're from is very important, I think. And something that I find amusing is when non-Indigenous people shadow me and I introduce myself. And if it's an elder from the community, who's your family? And, because they want to know who is my family, because they know I'm Alaska Native. And after we leave the room and the clinician has questions. So you self-disclose. I'm sharing where my, I said I have to. I'm Alaska Native and they want to know who my family is. So, yeah.
And I'm seeing some questions in the chat. So one of them being sharing suggestions on making evaluation work meaningful for both our federal funders and communities and providers. Um, Absolutely. And I see ourselves at Seven Directions, kind of that go-between, with some Western organizations and then with tribes and techs, and urban Indian organizations. And I think what is primary and what is most important is first hearing, from our American Indian and Urban Indian partners what they need in community. So that's where we start in terms of what is important, what is the effort that we're trying to take a look at, and how might you want to track that. And I didn't have the chance to go into in-depth Indigenous knowledge and thinking of that in a more holistic way. So, meaning thinking about empirical knowledge that is absolutely connected or collected in Indigenous communities, along with traditional and revealed knowledge. So when we think about traditional knowledge, what are some of the things that are handed down generation to generation that are integral knowledge pieces in terms of health, in terms of land management, all those pieces? And then when we think about revealed knowledge, thinking about, again, connection with ancestors, ceremony, things like that. And so when we often work with partners, we're looking at what are those pieces that are important in terms of collecting knowledge. How do we help you do that? And then how do we package that for Western funders? And oftentimes, what we see when we work with partners is, oh, I've been collecting evaluation the whole time. And I'll give one example of that. So we met with a tribe that was a substance use kind of provider base. And they were noticing that clients that they worked with were coming back over time and asking to celebrate their sobriety birthdays at the organization. So there's many people, one, that were achieving sobriety and long-term sobriety, and two, they wanted to use their organization as a celebration place for that. So then in working with those partners, we said, oh, can we make sure we track this in a non-identifiable way that these many people are achieving sobriety and asking for this, and then presenting that to funders. So a lot of it is kind of that translation of things, and that most of our partners are collecting really valuable data already. So those are a couple things that come to mind. And then I think I saw some other questions in the chat as well. Trying to, and sorry, I'll give one other example that I think is important is for our funders, we collect and present these pieces in different ways. So oftentimes we have feedback from our partners in terms of in a written feedback or in a video feedback or in different feedback forms that they then can understand kind of the importance of it and how much work is already being done. Let's see. I see from Mela, I hope I'm pronouncing that correctly. Does your program work with kids in the foster care system? And do they have services for trauma? And was that for different panelists or for Seven Directions, that question? It looks like Evie's already answered that for a yes. At Seven Directions, we don't do direct clinical services. So for us, the way that we have addressed some of those pieces is we actually have an adverse childhood experiences toolkit that focused on that public health effort and looked at how, again, there's translation in our approaches for things like adverse childhood experiences, driving under the influence, and suicide prevention. And all of these are on our website as well, which is noted in the contact.
And I'll note for NWATTC, we also don't provide direct services. It's mainly training and helping direct service providers. So yeah.
To speak to my work outside of NWATTC, we do work with foster care programs, OICW specifically, but also DCYF for those situations in this urban setting that I'm in the greater Seattle area. All of our relatives, unfortunately, do not fall into that category that the federal government has stated what makes you Native, which we all know isn't the case. It is just a designation that the government stated is what it is. And so in those cases, we are working with systems that work with our Indigenous relatives in the foster care system that may not be OICW, which then translates into those other services such as SUD, medically assisted treatment, mental health. So we are providing those direct care services across the board in support of ensuring that those pieces of healing that need to be done within the family systems is being done, which relates back to the foster care system. So we do try our hardest to touch on all those points within the programming that I work within.
And I can add to 4 hours. I did say, yes, we do work with kids in the foster system. We also partner with Department of Justice and all the different tribes around the state to make sure that, like, if they have to attend substance use classes, anger management, parents have provide so that family can still office children's services and probation and parole guidelines. So if they're mandated, we can provide the services remotely.
Thank you, Evie. I'm seeing another question. How does this model recognize and adjust for levels of acculturation and assimilation? Great question. And I think a few things come to mind. One, we talk about space for consideration of values and where we're at. So when we as Seven Directions partner with an organization that has asked for partnership, and we often do 2-day intensive training events where we go to the location or to the tribe or the organization that has asked us for partnership. The first at least couple hours are just getting to know each other and doing so again in a really connecting way. So oftentimes there is space and discussion of acculturation and assimilation in that. And it naturally is something that comes up. The other thing that comes to mind for me is that this model very much takes into account how do we have deep community involvement. I didn't get a chance to go into this during the presentation, but there's many different sections in terms of how do we involve community? Are those elders? Are those youth? Are there other organizations? So how do we get that feedback in terms of culturally grounded approaches, if that is what the person or the organization wants? So in other words, if acculturation and assimilation has occurred and they want to have a reconnection with culture and with protocol, how do you ask for that? How do you have space for that? And how do we also navigate the important feelings that come up with that? So I think, again, the model, we're not good with brevity in our toolkits. So it's about 100 plus pages. And there are spaces in there for that. Also, as a direct service provider, I think that's something that sitting with feelings and sitting with experiences is something that I really enjoy and that I notice that is kind of embedded in the work that we do. Anyone else have thoughts on that piece? How you might navigate that in your different organizations?
We partner with all the communities that we work in, and we attend they all have, what do you call them? Like representatives from each of the communities join our meetings, so our health director meetings and board meetings. So there's always someone from each community that we serve that represents that community. And then also when our clinicians go to the communities, there's always someone that we can connect them with that gives them a tour of the town and, who's who and what's what and where to go for everything. So it's so nice when we get a new clinician, say from New York or Miami, and they get sent out to St. Paul, and you have somebody come to the clinic and drive them around and just give them the cultural history of the community the very first day that they're there. So just building those warm connections.
I'm looking at our time, and in terms of the last question that I see, slides will be available, and Meg and Jen, I think the recording will also be available. Is that correct?
Yes. Yeah, we should have that up on the website later this afternoon or tomorrow.
Okay. Well, thank you so much, everyone, for the space and the time. Please feel free to reach out and connect with us. And I think we just have some last wrap-up pieces in terms of feedback forms and otherwise.
Yeah, I just have a couple of quick announcements, but thank you so much to our presenters today. This was really great content, and thank you to our participants for taking time out of your day to join us. Please remember to take our evaluation survey for today's webinar so that we can continue to offer these free sessions for you. And please join us on August 27th for our next webinar. It'll be titled Employee Engagement Strategies for Success, and that's presented by Amy Shanahan. And yeah, thank you so much. And you have our contact information up there on the slide, but feel free to reach out to us. But we'll have some more information that goes out in an email to you later today.